Hello, everyone. Welcome to our lecture on heart failure, which is a really important topic within our concept of perfusion. So today we're going to talk about what heart failure is, why it happens, and how it impacts the body. Heart failure is a leading cause of hospitalization, especially among our older adults. It happens when the heart isn't able to pump blood effectively, meaning all of our vital organs and tissues don't receive enough oxygen and nutrients to be able to function properly. So throughout this lecture, we're going to break down the causes of heart failure, the different types, and the clinical manifestations you need to recognize as a nurse. All right, so now let's look at the pathophysiology of heart failure. And this is oftentimes referred to as pump failure because the heart is not able to function effectively as a pump. Heart failure arises from a variety of different acute and chronic cardiovascular problems, including coronary artery disease, high blood pressure, and different structural abnormalities of the heart. Heart failure is a chronic condition, but it can have acute exacerbations that oftentimes will lead to hospitalization. And if it's left untreated or if a patient doesn't respond to therapy, it can become life-threatening. So now we're going to break down some of the major types of heart failure. First is left-sided heart failure. And this happens when the left ventricle struggles to pump blood forward into systemic circulation. So blood backs up into the lungs. Right-sided heart failure occurs whenever the right ventricle fails to pump blood into the lungs, and so blood backs up into the systemic circulation. High output failure is less common, but it occurs when the body has an increased demand for blood flow that the heart just can't meet, despite having normal or even elevated cardiac output. So typically, heart failure begins on the left side. Remember, that left ventricle is the workhorse. It's the one that's got to get blood to the rest of the body. So if left-sided heart failure is left untreated, it can progress to involve both of the ventricles, which leads to worsening symptoms and other complications. So if you take a minute to look at the picture on the slide, you can see all of the different chambers of the heart, the left ventricle, left atrium, right ventricle, and right atrium. And if you really think about the way blood flows, you can really understand why if one ventricle isn't working, how fluid would back up and why it goes where it goes and why we see the symptoms that we see. And we'll talk about those a little bit more in depth here in just a few seconds. All right, so first, to fully understand heart failure and what's going on with heart failure, we need to break down cardiac output and the two critical factors that influence it, and that is preload and afterload. So heart failure occurs whenever there is an interference with the mechanisms that regulate cardiac output. Cardiac output is the total volume of blood that's pumped by the heart in a full minute. It's determined by the formula cardiac output equals stroke volume times the heart rate. Now, stroke volume refers to the amount of blood that's ejected from the left ventricle with each heartbeat. All right, so now we're going to break down preload and afterload, both of which affect stroke volume and therefore overall cardiac output. So preload refers to the amount of blood in the ventricles at the end of diastole. That is the heart's relaxation and filling phase. So we want to think of preload as the stretch on the heart muscle before it contracts. The more blood that fills the ventricle, the greater the stretch. Increased preload occurs in conditions like hypervolemia or fluid overload and in heart failure because the ventricles retain more blood. Afterload is the resistance that the left ventricle has to overcome to eject blood into circulation. If afterload is high, then the heart's got to work harder to pump that blood forward. High blood pressure and vasoconstriction both will increase afterload, which makes the heart's job much more difficult, and it leads to an increased cardiac workload. So now how does all of this relate to heart failure? Well, if the preload is too high, then the heart becomes stretched and weakened over time. And if the afterload is too high, then the heart has to work much harder to pump against that resistance, which can lead to left ventricular hypertrophy or enlarging of the left ventricle and eventual heart failure. So now let's discuss one other thing, and that is ejection fraction. So ejection fraction is the amount of blood that's ejected from the left ventricle during systole. Remember, systole is that squeezing phase or the contracting phase. So ejection fraction tells us just how effectively the heart is pumping. A normal ejection fraction is 50 to 70%. Now we have a couple of different types of heart failure, especially when we talk about left-sided heart failure, which we'll talk about in just a minute. But we also have, within our left-sided heart failure, we can have a systolic heart failure, which it's called heart failure with reduced ejection fraction. And this is where the ejection fraction actually drops below 40%. So that means that less blood is being ejected with each heartbeat. Another side of left-sided heart failure, another type of left-sided heart failure is diastolic heart failure. And this is known as heart failure with preserved ejection fraction. So here, the ejection fraction remains normal, but that stiffened ventricle doesn't relax and fill properly, hence the diastolic phase. And this leads to inadequate cardiac output. Don't worry, we're going to talk about these two, I think, on the next slide, so don't panic yet. So really, you just know that you've got to understand preload, afterload, and ejection fraction, and how they affect stroke volume, and therefore how it affects cardiac output. So if you think about all of that and how we can treat these and how we can manage heart failure, then you understand how our different treatments like diuretics and vasodilators and beta blockers will target these factors so that we can reduce the cardiac workload and hopefully improve our heart function. But I promise we'll get to that. Just give me some time. All right, so now we're going to focus just on left-sided heart failure, which was previously known as congestive heart failure, or CHF. CHF is still commonly used in most clinical settings. It's important to note that, however, not all cases involve fluid overload or fluid accumulation. So let's talk about the causes of left-sided heart failure. So the most common causes are things like high blood pressure, which increases afterload and makes it harder for the heart to pump, coronary artery disease, which limits blood supply to the heart muscle, and valvular disease, which disrupts the normal blood flow to the heart. So left-sided heart failure results in a decreased cardiac output and pulmonary congestion. So as the left ventricle fails, blood is going to begin to back up into, again, we're in the left ventricle, it's going to back up into the left atrium and back up into the pulmonary circulation, which leads to symptoms like dyspnea or difficulty breathing. We see orthopnea, which is difficulty breathing whenever a patient's lying down. And in severe cases, we see pulmonary edema. So with left-sided heart failure, like I mentioned on the previous slide, it's classified into two main types. We have systolic heart failure and diastolic heart failure. So systolic heart failure is also known as heart failure with reduced ejection fraction. So this happens when the heart muscle is too weak to pump blood forward effectively. And as a result, the ejection fraction is going to drop below 40%, meaning that the lower than normal percentage of blood is being ejected with each heartbeat. So because of the poor pumping ability, blood is going to back up into the lungs, like I just talked about, and cause that fluid accumulation and impaired oxygenation. Patients who have an ejection fraction of less than 30% are at a high risk for sudden cardiac death, and they may require an implantable cardioverter defibrillator, or ICD, to prevent any life-threatening arrhythmias. Diastolic heart failure, which is also known as heart failure with preserved ejection fraction, in this case, the heart muscle becomes stiff and it doesn't relax properly. Again, that during diastole, that's when the ventricle relaxes and fills. So it can't relax properly like it needs to. So in a diastolic heart failure, even though the ejection fraction is going to remain normal, the ventricle doesn't fill adequately, meaning that the total volume of blood pumped is still going to be insufficient. So this type of heart failure is much more common in older adults and in women with chronic high blood pressure. So again, just to kind of reiterate here, systolic heart failure is going to be a problem of weak contraction, and diastolic heart failure is going to be a problem of poor relaxation. Both of these still result in poor tissue perfusion and fluid overload, but the treatment strategies may vary for each one. All right, now we're going to discuss right-sided heart failure, which differs from left-sided failure in its causes, its pathophysiology, and its clinical manifestations. So causes of right-sided heart failure, usually right-sided heart failure is a consequence of left-sided heart failure, just simply due to the increased pressure in the pulmonary circulation. Remember that left ventricle is not working, so blood backs up into the left atrium, which backs up into the lungs. And that right ventricle is trying to push blood to the lungs. Well, they're already full of fluid because the left ventricle doesn't work. So that puts more strain on your right ventricle, and now we end up with a right-sided heart failure. There are some other causes. Other causes of right-sided heart failure would be a right ventricular myocardial infarction, which would directly weaken that right ventricle, and also pulmonary hypertension, which increases the resistance that the right ventricle needs to pump against. So let's talk about what happens in right-sided heart failure. So in this condition, the right ventricle can't pump effectively. So it cannot effectively empty out. So that causes a backup of blood into the right atrium and back into the venous system. So this causes increased volume and pressure in the systemic circulation. So because of this, we see things like peripheral edema, mostly in the lower extremities. We see jugular venous distension just simply due to that increased venous pressure. We can see ascites or fluid accumulation in the abdomen. We can also see hepatomegaly and splenomegaly, which is just big words for enlargement of the liver and the spleen due to that venous congestion. So the key difference between left-sided and right-sided heart failure is that left-sided leads to pulmonary congestion, while right-sided failure causes systemic venous congestion. So again, if you look at this diagram here on the slide, you can see how blood flow through the heart is affected. When the right ventricle fails, blood can't move efficiently into the pulmonary circulation. So that causes a backup into the venous system. So this explains why patients who have right-sided heart failure will present with swelling in their legs, distended neck veins, and fluid retention in their abdomen. Managing right-sided heart failure requires treating the underlying cause, whether it's that pulmonary hypertension, an MI, or progression from left-sided heart failure. Also, while managing symptoms like fluid retention and venous congestion. All right, so in order to properly diagnose and manage heart failure, we use a standardized classification and staging system. The two most commonly used are the New York Heart Association Functional Classification and the American College of Cardiology and American Heart Association staging system. So these classification systems help to guide treatment and track the progression of heart failure over time. The New York Heart Association Functional Classification, this system categorizes patients based on their symptoms and how much of their daily activities are affected by the heart failure. So with Class 1, this is mild heart failure. There's no limitation of physical activity, and patients can exercise normally without any symptoms. Class 2 is mild as well. Here is just slight limitation of physical activity, but patients are comfortable at rest, but they may experience symptoms like fatigue, dyspnea, or palpitations with ordinary activity. Class 3 is moderate. So here we have a marked limitation of physical activity. Even less than normal activity can cause symptoms in these patients, but the patient is still pretty comfortable whenever they're at rest. And then stage 4 or class 4, which is severe. So symptoms here occur at rest and worsen with any sort of physical activity. So this would be end-stage heart failure, where patients may need advanced interventions like a heart transplant or mechanical circulatory support. So looking at the American College of Cardiology and the American Heart Association staging system, so the New York Heart Association classification focuses on symptoms, but the ACC-AHA system really bases theirs on disease progression and the structural changes within the heart. So for the ACC and AHA, they have stage A, and this patient would be high risk for developing heart failure, meaning that they have all of the risk factors. Stage B would be patients who have cardiac structural abnormalities or remodeling, but no heart failure symptoms yet. For example, they may have that left ventricular hypertrophy, or they may have had a previous heart attack, but they haven't developed heart failure. Stage C would be patients who currently have or previously had symptoms of heart failure, such as shortness of breath, fatigue, or fluid retention. And stage D are patients with refractory end-stage heart failure, meaning that their symptoms persist despite maximum medical therapy. So these patients often require advanced treatments, again, like ventricular assist devices or heart transplant. All right, so let's talk about the different compensatory mechanisms that our body has whenever the heart is failing and cardiac output is insufficient to meet our body's demands. Our bodies are really cool. Whenever it senses that, hey, we're not getting enough blood or perfusion to our tissues and organs like we need because the cardiac output's insufficient because the heart's not working, the body has these series of compensatory mechanisms. Well, and they're really good at first. These mechanisms are initially very helpful, but when we talk about, how these different mechanisms work, you'll understand how over time they can actually worsen heart failure and actually contribute to the progression of the disease. So the four major compensatory mechanisms that we're going to talk about are going to be the sympathetic nervous system, or SNS stimulation, the renin-angiotensin-aldosterone system activation, some other chemical responses like B-natriuretic peptide or BNP, and also myocardial hypertrophy. So on the next few slides, that's what we're going to be talking about, and maybe that'll help you understand why we do certain medications that we do to help treat heart failure. All right, so that first compensatory mechanism we're going to talk about is the sympathetic nervous system, or SNS. This is the body's most immediate response to that low cardiac output in heart failure. This compensatory mechanism is activated when tissue hypoxia occurs, meaning that the body is sensing that organs and tissues aren't getting enough oxygen-rich blood. So here's how the SNS tries to help. When cardiac output drops, the sympathetic nervous system releases catecholamines, including epinephrine and norepinephrine, which stimulate adrenergic receptors to increase the heart rate and increase the blood pressure. They're going to increase stroke volume and contractility, and they're also going to cause arterial vasoconstriction. So let's talk for a second about that increase in heart rate and blood pressure. So beta-adrenergic stimulation increases the heart rate to temporarily improve that cardiac output. Remember, cardiac output is equal to stroke volume times the heart rate. So if we increase the heart rate, we're going to improve our cardiac output. However, if our heart rate becomes too fast, then the heart's going to have less time to fill during diastole, which leads to a decreased stroke volume and a reduced cardiac output over time. Also, an increased heart rate is going to raise the myocardial oxygen demand, which can actually further worsen our heart failure, especially in patients who have coronary artery disease. Let's talk about how the SNS increases stroke volume and contractility. So SNS stimulation increases venous return to the heart, stretching those myocardial fibers. There's actually Starling's law that exists, and it states that the more the heart muscle is stretched, then the more forceful the contraction is going to be. And this is true up to a point. Too much stretch is going to lead to ventricular dilation and decreased contractility, which again, this starts out great, but it can make heart failure worse in the long run. Lastly, we have the arterial vasoconstriction that's caused by the SNS activation. So alpha adrenergic stimulation causes vasoconstriction, which is going to initially help to maintain that blood pressure and improve our tissue perfusion in a low output state. However, vasoconstriction is going to increase our afterload. So this means that the left ventricle is going to have to work harder to eject that blood. Increased afterload also equals increased myocardial oxygen demand, which is going to further weaken that failing heart. So you can see while the SNS initially helps to maintain blood pressure and cardiac output, chronic SNS activation leads to persistent tachycardia, which increases that myocardial oxygen demand and contributes to worsening heart failure. It increases afterload, which makes it harder for the heart to pump, and it causes ventricular remodeling, which leads to hypertrophy and fibrosis of the heart muscle. So this is why beta blockers, which block that SNS activity, are such an important part of heart failure treatment. They slow the heart rate and reduce afterload. Beta blockers help improve long-term heart function. All right, our next compensatory mechanism is the renin-angiotensin-aldosterone system. And this becomes activated in response to low cardiac output and reduced renal perfusion. So again, we're not getting enough blood out to the body and the tissues, especially the kidneys, and the kidneys are not going to be happy about this. So it starts this cascade, which is called the renin-angiotensin-aldosterone system, or the kidneys do. So again, same as the SNS, this system initially aims to maintain blood pressure and perfusion, but its long-term effects are going to also contribute to worsening heart failure. So let's talk about how this is activated. So whenever a cardiac output drops, the kidneys are going to receive less blood flow, which triggers the release of renin. Renin converts to angiotensinogen, which is produced by the liver, and then it converts into angiotensin 1. Angiotensin 1 is then converted into angiotensin 2 by what's called angiotensin converting enzyme. I think we've heard of a medication called angiotensin converting enzyme inhibitors, or ACE inhibitors, or PRIL medications. They prevent this conversion of angiotensin 2. And again, angiotensin 2 is a powerful vasoconstrictor. So that's why these inhibitors, they're going to prevent this vasoconstriction from happening. So back to our cascade here. Angiotensin 2, again, is that powerful vasoconstrictor, and so it's going to increase the blood pressure and it's going to increase the afterload, which again is going to put more strain on this failing heart. It initially starts because it's increasing that cardiac output. Our body needs that oxygenation, but it makes things even harder for the heart that's already struggling. So let's talk about the different effects of the RAAS activation. So first, we have vasoconstriction, like I just talked about. So angiotensin 2 causes widespread vasoconstriction. It raises the blood pressure and it increases afterload. Again, forces the heart to work harder, which worsens heart failure over time. Aldosterone is going to be released by the adrenal glands. So this is going to promote sodium and water retention. So this is going to increase blood pressure, but it's also going to increase the preload. It's going to increase our fluid volume. So this leads to more fluid overload, pulmonary congestion, and peripheral edema. We also have increased antidiuretic hormone, or ADH. So the pituitary gland is going to release antidiuretic hormone, which is also going to further promote our water retention. This is, again, going to exacerbate our congestion and it's going to increase the workload on the heart. It's also going to increase our SNS activity. So angiotensin 2 also further stimulates the sympathetic nervous system, which again is going to increase our heart rate and increase our contractility. Again, we know that this helps in the short term, but chronic SNS stimulation contributes to that tachycardia, that increased oxygen demand, and further stress on the heart. Lastly, with this system, we see what's called ventricular remodeling. So angiotensin 2 contributes to ventricular hypertrophy, which is enlarging of the ventricle, and fibrosis, which is like scarring. So we see, in the end, a stiffened heart wall and a worsening contractile dysfunction. So this structural damage makes the heart progressively less efficient at pumping blood. So you can see, although the RAAS activation is meant to maintain perfusion, the long-term effects cause fluid overload, they increase afterload, and they cause cardiac remodeling, which again is going to make everything so much worse. So how do we treat this part? Obviously, I already talked about one of them, ACE inhibitors like lisinopril. We can also use our angiotensin receptor blockers or ARB medications. And then we can also use diuretics to help reduce fluid retention, aldosterone antagonists like spironolactone. That can be used to help counteract the sodium and the water retention. So you can see how by using medications and by targeting the RAAS system, we can slow the progression of heart failure and hopefully improve the patient outcomes. All right, so now let's talk about some other compensatory mechanisms, and we're going to go over some of the different chemical mechanisms that occur. So first is the immune response to the myocardial cell injury. So whenever the heart cells become damaged, such as after an MI, the immune system responds by releasing pro-inflammatory cytokines, things like tumor necrosis factor and different interleukins. These contribute to ventricular remodeling, which leads to fibrosis and weakening of the heart muscle. This is especially going to be prominent in left-sided heart failure and plays a huge role in disease progression. Second, we have natriuretic peptides or neurohormones. So these hormones are the body's natural response to fluid overload. And the most significant one in heart failure is the B-type natriuretic peptide, or BNP, which is released by the ventricles whenever they stretch due to that excess fluid. So BNP works to promote vasodilation, which is going to reduce our afterload, and it also is going to help to increase diuresis by encouraging sodium and water loss. So a BNP level is what we draw in clinical practice to help assess the severity of heart failure. And we'll talk a little bit more about that here in just a little bit. Another chemical mechanism, so again, we kind of talked about this a little bit earlier, that low cardiac output in vasopressin or antidiuretic hormone release. So whenever cardiac output falls, cerebral perfusion is going to be decreased. So we see that activation of the posterior pituitary gland releasing antidiuretic hormone. So this is going to promote fluid retention and it's going to cause vasoconstriction. Again, it's going to make things worse for the heart failure. Fourth, we have endothelin secretion. So endothelin is a potent vasodilator. It's released by the endothelial cells when they are stretched. It increases peripheral resistance and blood pressure, which again is going to worsen our heart failure. And lastly, we have myocardial hypertrophy and dilation, and this is the heart's last effort to compensate. So as a final compensatory response, the heart undergoes hypertrophy, where the heart walls thicken, which increases muscle mass to produce stronger contractions. However, this rapid muscle growth is going to outpace the heart's blood supply. So that's going to lead to further oxygen deprivation. And over time, that hypertrophy is going to lead to stiffening and reduced efficiency, which again is going to worsen our heart failure. So the big picture here, all of these compensatory mechanisms initially work to maintain perfusion, but over time, they're going to increase our cardiac workload, they're going to increase fluid overload, and ultimately worsen our heart failure. So you can see why medications like our ACE inhibitors, our beta blockers, diuretics, natriuretic peptide therapies are all key components of our heart failure management. All right, so now let's look at the etiology and the incidence of heart failure. So our etiology is what causes heart failure. Again, there's several factors that contribute to heart failure development, but the most common causes are systemic hypertension, which obviously is going to increase afterload, making the heart work harder over time, which is eventually going to lead to ventricular hypertrophy and heart failure. Another cause is a myocardial infarction. Damage to the heart muscle from a heart attack can weaken its ability to pump. And three are structural heart changes. So conditions like aortic or pulmonic valve stenosis create a pressure overload, which is going to make the heart have to work harder. Another cause, we can have right-sided heart failure from pulmonary disease. So in the absence of left-sided heart failure, chronic lung conditions like COPD or pulmonary hypertension can lead to what's called cor pulmonale, which is a form of right-sided heart failure due to an increased resistance in the pulmonary circulation. Incidence and prevalence. So let's talk about how common is heart failure. Well, heart failure affects over 6.5 million people in the U.S., and it's expected to rise to over 8 million by 2030. It is the leading cause of hospital admissions in people over 65. African Americans under age 50 have a higher incidence of heart failure than your Euro-Americans, largely due to an increase in the prevalence of high blood pressure, diabetes, and other risk factors. Okay, now that we understand the patho and the different causes of heart failure, we're going to focus on how we can assess a patient with suspected heart failure. And as always, we're going to start with our history. So, what to ask the patient? First, we need to identify any history of heart conditions. So, we want to ask the patient if they have hypertension, coronary artery disease, or a previous myocardial infarction. Ask whether or not they have a valvular disorder, a cardiomyopathy, or a cardiac infection. Something like endocarditis or pericarditis. We also want to ask the patient about their activity tolerance, more so their exercise capacity. So do they feel fatigued more easily, or do they get short of breath with routine activities? We also want to ask the patient about their breathing, sleeping, and urinary problems. So patients with left-sided heart failure often have dyspnea on exertion, orthopnea, or what's called paroxysmal nocturnal dyspnea, which is where they wake up gasping for air during their sleep. Their urinary changes, so patients may experience that nocturia, and this is an increase in nighttime urination just simply due to fluid shifting whenever they lay down. We want to ask the patient about their fluid status, so asking about swelling in the legs, any weight gain, or feeling of like they're full in their abdomen. All of these can indicate fluid retention, especially in right-sided heart failure. We also want to assess the patient's knowledge of heart failure, making sure that they understand the condition and why it's important to adhere to their treatment. Non-adherence to medications, diet, or lifestyle changes can really exacerbate symptoms and lead to hospitalization. Okay, so now we're going to focus on the clinical manifestations of left-sided heart failure, which primarily result from decreased cardiac output and that pulmonary congestion. So what happens when the left ventricle fails? So again, whenever the left ventricle can't pump right, the body's organs and tissues don't get enough oxygen-rich blood. So we see fatigue and weakness. Our patients oftentimes will struggle with activity tolerance, and report feeling heavy in the arms or the legs. They have dizziness and confusion due to reduced cerebral perfusion from low cardiac output, and they can have chest pain or palpitations because as the failing left ventricle strains to keep up, the heart can start to develop tachycardia and different irregular rhythms like PVCs or even atrial fibrillation. And even patients can experience that chest pain or angina. So pulmonary congestion and pulmonary edema are the hallmark of left-sided heart failure. So again, as that left ventricle fails, blood is going to back up into the lungs, which is going to cause pulmonary congestion and respiratory symptoms. They're going to have a cough. Usually it's dry and unproductive at first, and it gets worse at night. It may progress to have a pink tinged frothy sputum, which is a sign of pulmonary edema, which is a medical emergency. The patient's going to have dyspnea or shortness of breath, especially exertional dyspnea where they have difficulty breathing with activities. Again, they can develop that paroxysmal nocturnal dyspnea, which is where, again, patients wake up suddenly gasping for air just simply due to that fluid shifting into their lungs when they lay down. They can also have orthopnea, which is difficulty breathing while they're lying flat. Oftentimes, patients will sleep with multiple pillows or even in a recliner so that they don't have that difficulty breathing while they're laying flat. They want to sleep propped up. That's another big history question that we want to ask them. Like, how are you sleeping? Do you sleep in a recliner? Do you sleep with a bunch of pillows? But back to our actual physical assessment. So with the pulmonary congestion, obviously we want to assess these patients' lung sounds. We're going to hear fine inspiratory crackles. This is the result of fluid in the alveoli, which can worsen as heart failure progresses. Patients may also have wheezing because they can have a narrowed airway due to that pulmonary congestion. Typically, these lung sounds are going to start in the bases of the lungs, and as fluid builds up, they're going to start moving up in the lungs. Patients with left-sided heart failure can also have irregular heart rhythms and a higher risk of developing atrial fibrillation. So the failing left ventricle is really prone to developing arrhythmias. Again, premature atrial contractions or PACs, premature ventricular contractions or PVCs, and AFib, which is a very common complication, and it increases the patient's risk of stroke. So kind of the big picture, left-sided heart failure affects the entire body by reducing oxygen delivery and causing fluid buildup in the lungs. All right, so now we're going to talk about right-sided heart failure, which again, primarily is going to lead to systemic congestion due to the inability of the right ventricle to effectively pump blood into the pulmonary circulation. So again, can't pump blood forward into the lungs, so it's going to back up into the body. So first things that we see, we're going to see obviously fluid retention. So we're going to see edema. This is typically going to begin in the lower extremities, but it may progress to the thighs, the abdominal wall, the hands, and the fingers. Pitting edema can develop, but remember, edema is really kind of an unreliable indicator of fluid retention because significant fluid accumulation can actually occur before any visible swelling appears. That's why getting those daily weights is going to be the most accurate way to monitor fluid status. Gaining 2 to 3 pounds in like a day or 5 pounds in a week is a huge red flag for worsening heart failure. Second, with fluid retention, we're going to see jugular venous distension. This is a hallmark of right-sided heart failure. We may also see hepatomegaly or enlargement of the liver, as well as some other GI symptoms. So the liver becomes engorged, so we see right upper quadrant pain. We may see nausea, vomiting, and anorexia just simply due to that increased abdominal pressure. And ascites can also develop, which leads to an increase in the patient's abdominal girth and further discomfort. These patients will have diuresis at rest and nocturia. So again, whenever the patient lays down, fluid is going to shift from the extremities back into circulation, which leads to very frequent nighttime urination. And lastly, these patients are going to have a lot of fatigue and obviously weight gain. So that fluid retention contributes to rapid weight gain, which again, early warning sign of worsening heart failure. And they have fatigue just simply because of that decreased cardiac output and tissue perfusion. All right, so whenever we're evaluating a patient for heart failure, our lab and imaging assessments play a big role in confirming the diagnosis and helping to guide treatment. So first we're going to look at our lab assessments. Electrolyte imbalances are common, particularly due to complications of heart failure or diuretic therapy. Sodium, potassium, magnesium, calcium, and chloride levels all need to be closely monitored. Renal function is also going to be assessed because poor cardiac output can impair the kidney function or kidney perfusion, which leads to an elevated BUN and elevated serum creatinine. Also, hemoglobin and hematocrit tests can help identify whether anemia is actually contributing to the heart failure. If fluid overload is present, then hematocrit levels may be artificially low due to that hemodilution. One of the most important biomarkers for heart failure is a B-type natriuretic peptide, or BNP, and also its related form, which is an NT-proBNP. So this is the heart failure lab. BNP is an active hormone that's released by the heart when the ventricles stretch due to fluid overload. It helps to promote vasodilation and diuresis to help reduce cardiac strain. However, it's not very effective. So we, in the lab, as far as drawing assessments, we're going to draw a BNP or a NT-proBNP. An NT-proBNP is an inactive byproduct, and it remains in circulation much longer than a normal BNP, which makes it a more stable marker for heart failure severity. So higher BNP or NT-proBNP levels indicate worsening heart failure, while a normal or a low level can just help rule it out. So a BNP level above 100 or an NT-proBNP level above 450 suggests that the patient does have heart failure. We can get a urinalysis that may reveal some proteinuria and a high specific gravity. And they can also have some microalbuminuria, which can serve as an early warning sign of heart strain before any symptoms actually occur. Arterial blood gases are going to be assessed to evaluate the oxygenation and acid-base balance. Moving on to our imaging assessment. So a chest x-ray can reveal signs of left ventricular failure because we can see an enlarged heart or cardiomegaly, as well as we can see pulmonary congestion in the lungs. However, echocardiography is going to be our gold standard for diagnosing heart failure. It provides very important information about the chamber sizes, valvular function, and ejection fraction, which helps us to determine heart function. Some other tools that we can use a electrocardiography or ECG or EKG. This helps to detect any arrhythmias, ischemia, and it can also tell us if there's some left ventricular hypertrophy occurring. Radionuclide studies such as a MUGA scan, which helps to provide precise measurements of ejection fraction. And in those critically ill patients, we want the hemodynamic monitoring so that we can assess that right atrial pressure. We can look at pulmonary artery pressures, and we can look at cardiac output. All right, moving on to analysis and implementation. So whenever we're analyzing and implementing our interventions for heart failure, we have three key areas that require our focused attention. That is gas exchange, perfusion, and pulmonary edema management. So first, our first priority problem is going to be decreased gas exchange. This is a very common issue in heart failure, especially that left-sided heart failure, due to ventilation and perfusion imbalances that are caused by pulmonary congestion. We'll talk about some of our different interventions for this, but it's mostly to increase gas exchange, which we can do through things like oxygen therapy, positioning, and deep breathing exercises, as well as different medications, and things that we can do to reduce pulmonary fluid buildup. Next, our next problem is going to be the potential for decreased perfusion due to inadequate cardiac output. So our interventions for here is obviously going to be to increase perfusion. So we might look at things like managing blood pressure, optimizing fluid balance, and using medications like ACE inhibitors or beta blockers or positive inotropes. Finally, we're also going to be watching out for the potential for pulmonary edema due to that left-sided heart failure. With this, our intervention is obviously going to be to prevent and manage that pulmonary edema by giving things like diuretics to reduce fluid overload and using oxygen therapy. So we'll look at all of these a little bit closer individually in the next few slides. All right, so ensuring adequate gas exchange is a critical priority in managing heart failure, especially for patients with pulmonary congestion. So our goal here is to optimize our patient's breathing pattern and maintain those normal serum carbon dioxide levels. To achieve this, there are several interventions that we can do. First, ventilation assistance might be required to improve oxygenation. So this would be like giving supplemental oxygen as prescribed to help maintain that O2 sat at 90% or greater. Patients who are having dyspnea need to be placed in a high Fowler's position, sometimes with pillows to help support their arms and to help maximize that chest expansion. Frequent monitoring is also really important. So the patient's respiratory rate, their rhythm, and the respiratory quality needs to be assessed every 1 to 4 hours, and lung sounds need to be auscultated at least every 4 to 8 hours. Also, repositioning every 2 hours along with coughing and deep breathing exercises is going to help prevent atelectasis and help promote effective ventilation. We may need to collaborate with a respiratory therapist as part of this patient's care because their expertise can really ensure that we're getting the most effective ventilation strategies. All right, so now let's talk about how we can increase perfusion. And first, we're going to talk about the different medications or drug therapy that we use to help improve cardiac output, reduce symptoms, and enhance these patients' qualities of life. So our key categories of drugs focus on reducing the preload, reducing the afterload, and improving cardiac contractility. So we're going to break down each class of medication as well as the role that they play in heart failure management and some examples. So first we have diuretics. So diuretics are first-line therapy for heart failure with fluid overload. They are going to reduce the preload and reduce fluid overload. So they help to reduce pulmonary and systemic congestion because they remove excess sodium and water from the body. However, it's important to know that we do need to be monitoring those electrolyte levels, especially potassium. So we can use loop diuretics like furosemide or butanide. These are used for significant fluid retention. We can use thiazide diuretics. Oftentimes these are going to be combined with our loop diuretics. These are medications like hydrochlorothiazide. And lastly, we have potassium-sparing diuretics, which help to prevent that hypokalemia while reducing fluid retention. And these are going to be medications like spironolactone. Since diuretics really only relieve symptoms without actually improving survival, they're going to be used in conjunction with some other heart failure medications. One of those is going to be vasodilators. And there's a few different vasodilators we're going to talk about. These medications help relax the blood vessels. They dilate the blood vessels. So they're going to reduce the workload on the heart because they reduce afterload and they improve blood flow, which is going to improve circulation. Nitrates are very common vasodilators that are used for these patients who have persistent heart failure symptoms. So we can utilize nitroglycerin. We can use another nitrate, which is isosorbide dinitrate or isosorbide mononitrate. Another medication we can use is hydralazine. This is oftentimes used in combination with our nitrates for patients who don't tolerate our ACE inhibitors. Our third types of drug is going to be an inotropic agent. These medications help to improve contractility of the heart. So they help the heart to pump more effectively, which increases, or it does so by increasing that contractility. We have cardiac glycosides like digoxin. This is a positive inotrope. This is used in chronic heart failure and it helps to improve symptom control. We can use beta blockers or beta adrenergic agonist. So again, those are typically, we think of these as like the OLA medications, but here, as far as inotropic agents, we're talking about things like dobutamine. So these are used in acute heart failure via IV administration. So since inotropic agents increase myocardial oxygen demand, they need to be used very cautiously, especially in patients who have ischemic heart disease already. Our fourth medication we can use is morphine. So this is used in acute heart failure. It's not routinely used, but it may be administered in those who have acute decompensated heart failure to help reduce the preload and help to reduce the afterload. It can also be used to decrease anxiety and that dyspnea that these patients are having. However, again, we want to use this cautiously because we want to avoid respiratory depression. Our next class of medications that we use to help increase perfusion are ACE inhibitors. So we already kind of talked about these a little bit. So ACE inhibitors reduce afterload and they prevent cardiac remodeling. So ACE inhibitors are the cornerstone therapy for heart failure patients because they reduce mortality and they slow disease progression. So again, these are your pril medications, enalapril, lisinopril, captopril. However, it's important to note with these medications, as far as your nursing considerations, we need to monitor these patients for hypotension, hyperkalemia, and angioedema. And again, ACE inhibitors, they're preventing that conversion of angiotensin 1 into angiotensin 2, which is that strict or very potent vasoconstrictor. So it prevents that vasoconstriction from happening. Our next medication for patients who don't tolerate ACE inhibitors, because ACE inhibitors can sometimes cause a dry cough or even angioedema, patients may be put on an angiotensin 2 receptor blocker. So again, these provide very similar benefits because they really essentially do the same thing. They're preventing that angiotensin 2 vasoconstriction. But typically, this doesn't come with that persistent cough that a lot of patients may get with an ACE inhibitor. So our medications, angiotensin receptor blockers, these are your sartan medications, like losartan, valsartan, those meds. And again, renal function and potassium levels still need to be monitored with these as well. Lastly, we're going to talk about our beta blockers. So again, beta adrenergic blockers help to reduce the heart rate and improve cardiac output because they're fighting that sympathetic nervous system stimulation. So beta blockers are very important in chronic heart failure. They improve survival, they reduce hospitalization, and they can prevent disease progression. These are going to be your OLA medications, so carvedilol, metoprolol. With these medications, it's important that we want to start them on a low dose and titrate gradually. And two, with these, we always want to teach our patients not to take these medications if their heart rate is less than 60 because they are going to decrease the patient's heart rate. All right, so now let's get into how we can increase perfusion using interventions aside from drug therapy. So starting with nutrition management. We may have some sodium and fluid restrictions for these patients. Nutrition plays a huge role in managing heart failure. So patients may be advised to follow a low sodium diet with restrictions typically going to be set at 2 to 3 grams a day. If fluid retention is a pretty big issue, then fluid intake might be restricted to 2 liters. But this is typically a less common intervention and usually reserved for very severe cases. Also with this, daily weight monitoring is going to be very important so that we can assess for signs of fluid overload. Some other non-pharmacological interventions that we may utilize to increase perfusion. We can do we can put a patient on CPAP or continuous positive airway pressure. So this is commonly used for patients who have heart failure and obstructive sleep apnea. It helps to improve oxygenation, it reduces the work of breathing, and it can decrease afterload, which leads to better heart function. A lot of times we will actually use this, I think I'll talk about it a little bit on the next slide. We use CPAP for acute pulmonary edema as well. Another intervention we can utilize is cardiac resynchronization therapy or biventricular pacing. So in some patients who have heart failure with reduced ejection fraction, that cardiac conduction has some abnormalities like a left bundle branch block, which can worsen cardiac function. And so cardiac resynchronization therapy, also known as biventricular pacing, is used to synchronize ventricular contractions. This helps to improve stroke volume and it reduces heart failure symptoms. Two other interventions, or two major surgical interventions for patients who have severe or end-stage heart failure are going to be to either have a heart transplant or have a ventricular assist device. So a heart transplant is going to be the definitive surgical option for patients who have end-stage heart failure who are not responding to therapy. So this procedure places a failing heart with a healthy donor heart, which will restore that normal cardiac function. However, there's a lot of challenges to this. There's limited donor availability, there's very strict eligibility criteria, and there's a lot of post-transplant care that comes into play with these. For those who are not going to be immediate candidates for transplant, though, or those who are waiting on a donor, then a ventricular assist device may be used as an alternative. So this is a mechanical pump that supports or replaces the function of the failing heart. So it's on the outside of the body for the most part. It helps to pump blood from the ventricles to the rest of the body. I say it's on the outside of the body. There is it goes into the heart, but it actually has a external battery that patients will need to carry around with them at all times to make sure that that pump is working correctly, or their left ventricular device is working correctly. So some key points about these. Ventricular assist devices can be implanted in either one or both ventricles, just depends on the patient's specific heart failure. A left ventricular assist device is the most common, and obviously it assists the left ventricle into pumping blood into the aorta. Ventricular assist devices really can serve as a bridge to a transplant. Again, these are going to be for those patients who are waiting for a donor heart, or maybe those who are just not a candidate for a transplant. All right, so now let's talk about how we can prevent and manage pulmonary edema, which is a life-threatening complication of heart failure that happens when we have excess fluid that fills the lungs, and this can lead to severe respiratory distress. For this, we need rapid recognition and immediate intervention so that we can prevent respiratory failure from happening. So we need to monitor for those early signs of pulmonary edema. So crackles in the lung bases, dyspnea at rest, disorientation and confusion, especially in our older adults. As this progresses, the patient is going to develop a frothy, blood-tinged sputum. They may have cold, clammy, or cyanotic skin, and they're going to have an increased work of breathing. Patients who have pulmonary edema oftentimes are also going to present with tachycardia, anxiety, and air hunger because they are struggling to breathe. So let's talk about what we do, our priority interventions. We're going to administer oxygen therapy immediately so that we can improve that gas exchange. Sometimes if supplemental oxygen alone isn't enough, then we escalate to CPAP or BiPAP or even sometimes mechanical ventilation. Positioning is very, very important. If the patient is not hypotensive, we want to place them in a high Fowler's position with their legs dangling. This just helps to reduce venous return to the heart, which is going to decrease that pulmonary congestion. We're also going to administer nitroglycerin. Sometimes we could do this. We may do, depending on the physician, they may order sublingual nitroglycerin every 5 minutes for 3 doses. As long as their blood pressure stays above 100, because again, this is a vasodilator. Nitroglycerin is going to drop their blood pressure. Nitroglycerin helps to reduce that preload and the afterload. Sometimes we do this by administering nitroglycerin as a transdermal paste onto their chest as well. We may administer rapid-acting diuretics like furosemide or Lasix. We may monitor their vital signs, or we're for sure going to be monitoring those vital signs every 30 to 60 minutes, paying very close attention to the blood pressure and to the respiratory status. We can administer IV morphine to reduce venous return, help with anxiety, and to decrease the work of breathing. And lastly, we may need to utilize ultrafiltration, such as like hemodialysis. And this is considered in cases of very severe fluid overload, renal dysfunction, or if the patient has diuretic resistance. All right, so heart failure, as we know, is a chronic condition. It requires continuous management and a very well-coordinated care transition so that we prevent hospital readmissions. Patients who are not adequately prepared for discharge, or maybe if they don't have enough community support, are going to be at a much higher risk of being re-hospitalized. And so to improve these outcomes, there are some national quality measures that emphasize early and intensive post-discharge care. So research has actually shown that at least 1 nursing visit on the day of discharge, followed by at least 3 more within the first week after discharge, can significantly reduce readmission rates. So as nurses, our role in care transition is very important. We need to make sure that the discharge instructions are clearly communicated, including the day and the time of any follow-up appointments, medication reconciliation, and any lifestyle modifications. We may need to collaborate with case managers and different care coordinators to help identify any potential barriers, such as obtaining medications or a lack of family support. All right, so now let's break down the essential components of home care management. So assessment and health teaching are going to be key to making sure these patients understand their condition. Lifestyle adjustments, including things like dietary restrictions, prescribed medications, and activity modifications, need to be reinforced as well. Getting into our self-management education. So a structured approach, like using the MAWDS, M-A-W-D-S, can help a patient take an active role to manage their condition. So M stands for medications. We're going to teach them to take their medications as prescribed, understand side effects. We may need to be teaching them to avoid NSAIDs. A stands for activity, so we want to teach them to stay active but to avoid any overexertion. W is weight monitoring, so we again weigh daily at the same time and report any rapid weight gain. D is for diet, so again limiting that sodium intake and possibly fluids. And S is going to be symptoms, so teaching them to recognize any worsening symptoms and to report them immediately to their healthcare provider. So some more education here. We want to teach or encourage that regular physical activity and possibly participation in a cardiac rehab program. This can help improve functional status and the patient's quality of life. And lastly, we have our healthcare resources. So support doesn't end just because we discharge these patients. Additional resources can be a big benefit. So home health, ambulatory follow-up clinics, nurse-led programs for medication adherence and symptom monitoring, as well as different educational tools and support from like the American Heart Association. All right, so our last step in management of heart failure is evaluation, making sure that our interventions are effective and that the patient is progressing toward an optimal outcome. So again, our 3 key indicators for evaluation are based off of our priority problems that we identified. So we want to make sure that the patient has adequate pulmonary tissue perfusion. This means that our patient has sufficient oxygenation and circulation in their lungs. We assess this by monitoring that respiratory rate, oxygen saturation, and their breath sounds. The absence of dyspnea, improved energy levels, and a lack of cyanosis all indicate that our pulmonary tissue perfusion is good to go. Our next problem that we want to evaluate if worked is going to be seeing if we have increased cardiac pump effectiveness and increased pump effectiveness. So our goal here is to improve the heart's ability to pump blood efficiently. So we evaluate this through stable and improved ejection fraction, normal heart rate and rhythm, and reduced symptoms of fluid overload, such as having a decrease in peripheral edema and improved activity and tolerance. So we use medications, lifestyle modifications, and different interventions to help achieve this outcome. And lastly, we want them to be free of pulmonary edema. So again, this is a life-threatening complication. Signs that this is successful would be clear lung sounds, no frothy sputum, and the patient reporting having improved breathing. Things that we do for this, effective diuresis, fluid balance, and adherence to medication and dietary restrictions can all contribute to helping this goal. So as you can see, all of our comprehensive interventions, very careful assessment, implementation, and evaluation, we can really help to optimize our patient's cardiac function. We can help to improve their perfusion, and we can hopefully prevent complications like pulmonary edema. All right, guys, that's all I have for this lecture. I will see y'all later.